All right, here we go. So thank you, Dr. Jasuja, organizers, for having me here today. It's always wonderful being back in Jaipur, and I've been given the massive task to discuss essentially the biomarkers, the molecular landscape of head and neck cancers. So without much further ado, let's get started. So basics, what do we know about head and neck cancers? So we know head and neck cancers are actually the 6th most common cancer worldwide. And in India, they definitely are far more prevalent and far more higher incidence rates because of our lifestyle choices. The key oncogenic driver over here is the human papilloma virus. Along with that, it is the abuse, I would say, rather than use of tobacco, in addition to the overconsumption of alcohol. The key treatment options that we do have for these are surgery, radiation, chemotherapy, while we do have targeted therapy. The unfortunate situation around head and neck cancers is that it presents usually in the 3rd to 4th, we kind of call it out in the 3rd to 4th stage when a patient visits us. And unfortunately, in 40 to 50% of patients, the overall survival is abysmal around around 5 odd years. So to combat all of this, I think as we've seen in other solid tumor cancers, we have seen better OS because of targeted therapy. So what does the molecular landscape look like? And I think head and neck cancers in particular are very, very unique and very different versus other solid tumors. And the reason being is, so this is the genomic alteration, and this is what really defines head and neck cancers and why it's such a unique field, and why treating it and why we really do not have a lot of targeted therapy around it is because so it starts off with it's dependent on something called loss of heterozygosity, which means the gain or loss of a chromosomal region. And it is this genomic instability, a collection of it, which eventually leads to the cancer. So it starts off as, and I'm talking about the squamous cell cancer in particular, which is the most common in head and neck. It starts off as a normal mucosa. There is a loss in the 9q21. 9q21, this region is where we have the tumor suppressor gene, which is the CDKN2A. CDKN2A, we know it encodes for the CDK4 and CDK6 P16 inhibitor. In addition, it's also the region for ARF, which is the P14. It encodes for P14, which actually stabilizes your P53. Then so this is from a normal, head and neck epithelial normal mucosa. This is the first step of change that happens, and it becomes a hyperplasia. So from hyperplasia to dysplasia, the genomic instability we see is 3p21 and 17p13. This is the region for TP53. Then from here, if it further progresses, so if we see a change of 11q13, 13q21, and 14q32, this is associated with carcinoma in situ. Or if we see a 6p8, 4q27, 10q23, this is associated with invasive carcinoma. So essentially, for a head and neck squamous cell carcinoma to present in your patient, it has to go through this journey, this collection, this progression of a whole bunch of tumor suppressor genes, which undergo genomic changes, which results in the cancer. Now, let's take a step back and think about lung cancer. You just need one oncogenic driver, one change in your EGFR, the disease presents. That's not the case in head and neck cancers. And keeping this all in mind, the TCGA, which is the Cancer Genome Atlas, did a very quick search. As Dr. Sharma very rightfully said, we don't have a lot of cases in the West, but we do have a lot in India. So over there, they took around 279 cases, if memory serves me right. And from them, around 36 were HPV positive and the remainder were HPV negative. And what they saw in all of this is that in the HPV negative, yes, there was a lot of genomic instability. We did see LOH across the board, which was one of the primary reasons for the onset of cancer. But in addition to that, we saw in 22% of cases where we saw over there a CDKN2A loss, which is at the early stage, and TP53 was as high as 72%. Interestingly enough, this was not the same molecular profile we saw in the HPV positive. And the reason being is that in the tumor biology of HPV positive, they have E6 and E7 proteins, which are positive. And this essentially leads to the inhibition of RB1 and TP53. And let's take one more step and just go further into the molecular landscape. I'm not going to go into into these complicated pathways and create an issue, but the three key pathways that are actually governing or controlling in this head and neck cancers is your MET, EGFR, and Notch. These three essentially are responsible for proliferation, migration, and overall cell survival stability. So if we look, and they're able to do this with their pathways of having RAS, MEK1, ERK1/2, you've got PI3K, you've got mTOR, you've got PTEN, you've got JAK, you've got STAT, and then you've got your P53. And as we know across the board, all of this in our head and neck cancers are dysregulated. So this chart actually becomes extremely important in understanding, as we are in a world of precision oncology and we all want to talk about targeted therapies. This particular, this particular animation, this particular flow chart actually helps us understand as to what could be the potential targets for our patients with head and neck squamous cell carcinoma. So we know that MET is a very common, well-known inhibitor for, is resistance mutation that we see for an EGFR positive patient. So we have upfront where there's very interesting studies going around in the realm of giving a patient with a MET, either a mutation or overexpression, capmatinib, and where those clinical trials are actually showing really good results. And in fact, I do know in one particular case, again, off-label, where we've actually given our patient capmatinib, and we've seen a brilliant response. Again, they had progressed on all lines of therapy, not the standard of care, young individual, and we did see a very good response. And that patient had actually progressed on EGFR, where they was given the monoclonal antibody cetuximab. So just again, it's interesting knowing these pathways. Now, if you come down to MET, another important regulator over there is MEK. MEK, again, we know the combination of MEK with BRAF, we tend to use it in a lot of our cancers, especially lung cancer. So in a case of head and neck, what they're seeing is trametinib. Again, very good studies over here that are showing that patients with head and neck squamous cell carcinoma who are given MEK inhibitors in the form of trametinib are having a very good response. So now we come on to EGFR. EGFR, we know, comprise, especially the amplification, is close to 80 to 90% of our Indian patients. The Western data is around 80% of overexpression. Your amplification mutations are around 15%. The FDA approval is for cetuximab, which is a monoclonal antibody. But if we take a step back, we do know that these patients, some respond well, some don't really respond well, or they really progress fast. And it's usually also a prognostic marker that says, it's a poor overall survival if there is an EGFR mutation. So there are interesting studies that have come out where they've used, now we're very familiar with erlotinib and afatinib, we use it in lung cancer, and we're very comfortable using it. So there's a very good study that's there in head and neck cancers where they've done a combination. One is where they've used erlotinib with a VEGF antibody like bevacizumab, and they've given it in your recurrent and in your metastatic cases where they've seen a very good survival, where the patients have had a fabulous response. However, in your localized disease, where they have given they're given erlotinib with a combination of cisplatin and radiotherapy, the patient has had zero response. So from a metastatic recurrent setting, good response, localized, not a really good response. If we look at afatinib, again over there, a combination of afatinib with methotrexate, patients have been responding well. These are, clinical trials. They're obviously not into clinical practice, but there's very promising data, and why this chart becomes so important. Now, when I was explaining the progression of when I was explaining the progression of head and neck cancers, I was essentially just talking about tumor suppressor genes, right? But interestingly enough, we do have PTEN and PIK3CA, which are common genes, which are oncogenes that we do see in head and neck cancers. And again, there are very good studies that have shown that giving, especially when you have a PTEN loss, something like everolimus, where a patient does essentially respond well. What's very interesting in our head and neck cancers is this JAK-STAT pathway, which is such an important pathway in head and neck cancers. We don't have reported mutations for patients within that pathway. It can be maybe because we don't test it, but it's a very important pathway because something like a STAT3 gene is actually indicative of a poor prognosis and the fact that your patient may not really respond very well to chemotherapy. So this is why, doing an overall molecular profiling does become important, if not from a treatment perspective, at least from understanding the biology of the tumor. And interestingly enough, in all of this, there is a lot of work happening with respect to targeted therapies. So when we go back to the TCGA website, we go back to the TCGA study, and what they were able to call out that there were around 11 tumor suppressor genes that are very common in our head and neck cancer patients. RAS is so common, right? When we talk about the other solid tumors, but in fact over here it's practically minuscule, and HRAS tops the list as high as maybe 3%, especially in our Indian patients. EGFR, we do know, is around 80 to 90%, especially amplifications. PIK3CA, PTEN, we've already discussed small percentages, but they do have we see more overexpression versus targeted versus a single mutation, a point mutation. So this is where we are today in 2022 with respect to our targeted therapies that are FDA approved. We do know pembrolizumab is for a PD-L1 positive on a CPS score. We do know pembrolizumab can be given in first line of therapy. These patients respond well. Second line for Nivo, MSI high, TMB high. We know pembrolizumab from our keynote trials and the various other trials are positive. AR, a simple IHC, which is synonymous with prostate and even triple negative breast cancers. Over here, we do have targets, and especially in your salivary gland tumors, patients respond very well. NTRK gene fusion, it's an agnostic marker where we talk of in other cancers 1%, 2%, but in salivary gland tumors, it's as high as 90%. HER2, again, an important resistance mechanism, is again a resistant mutation to an EGFR. So we have targeted therapy. So HER2, I think, is fast becoming an agnostic marker. EGFR, we've already discussed. And in addition to that, I've missed out on a very important biomarker, which is BRAF. BRAF2 is just recently gotten an agnostic approval. And this is some of the other agnostic markers that are fast making their way into head and neck cancers. We've got some amazing data with selpercatinib from the LOXO trials for our head and neck cancer patients. And again, a lot of other targeted therapies that are just around the corner. Just very quickly, I have 6 minutes, so I'm just very quickly going to walk you through the different. I have spoken a lot about biomarker tests. We're talking about biomarkers, what is important for testing, how do we test them? PD-L1, we know essentially from the Keynote 048 trials that upfront PD-L1 testing should be done. PD-L1 is only done by IHC on the tumor. There are some labs that are now doing it on circulating tumor cells using liquid biopsy. That is definitely something that is to look forward to in the future. But for today, due to paucity of time, I'm not going to talk about it, but some really good stuff happening there in India. The other two platforms that we use for immunotherapy is tumor mutation burden. Tumor mutation burden is essentially using an NGS platform where you have over 250 genes. It has to be over 250 genes. And you look at the exonic regions and you call out the genetic aberrations, the somatic aberrations, and you calculate it And based on that, that's how we call out tumor mutation burden. So essentially what you're saying is higher the mutation rate, higher the neoantigen, and the patient will actually respond well to immunotherapy. That's the basic concept of tumor mutation burden. So again, you're looking at the instability. Microsatellite instability, and the reason I put this here, we're very comfortable with IHC, but when we're using micro MSI testing using PCR and NGS, just so many methods going around. What you have to understand is MSI, again, these are short tandem repeats that are there across the DNA. And when a mismatch repair gene does not function properly, there are changes over there. So what these tests do, they look at 5 mononucleotide, they look at 5 components, which is essentially, NR20, NR21, NR24, BAT25, BAT26, and Mono27. These 5 markers, if there are 2 losses in them, that means it's MSI high and your patient will respond well to immunotherapy. If 2 or more losses. If it's just 1 loss, then it's MSI low, which means you can consider immunotherapy, but you may not get the ideal response. And the FDA-approved companion diagnostic is this particular kit that uses these 5 mononucleotides. So there's no scoring mechanism and all, because there are a lot of service providers that are using it. You have to go back and ensure that this is the standard of care that's being used for your patients. Right, sample type, tissue can be an issue, and because head and neck cancers are such a heterogeneous and have got a high tumor burden, in cases when tissue is an issue, we are using liquid biopsies, especially to call out mutations like HER2, NTRK. It becomes critical that if one standard of care is not available, one sample type is not available, we switch to the other sample type. So there are a lot of arguments that go around that should we do small panels, large panels? Should we just do single gene testing? Should we do IHC and all? So without belittling any particular platform, I think all our gold standards, you really can't ridicule and say, oh, no, this is better than the other. The reason why NGS today is fast becoming a preferred platform of choice is for a very basic reason, is that one shot, you not only get your targeted markers, where, and a very important point is because NTRK is a fusion, please ensure that it's RNA NGS and not DNA NGS. So if the NGS report comes back negative, or even for HER2, anywhere where you're looking for amplifications, which are essentially fusions, you want to ensure that your lab is doing RNA. So if it comes back negative, go back, ask your service provider, have you done DNA NGS or RNA? If it's DNA NGS, I very strongly urge you to go and do it on RNA, because there is a discordance as high as 15%. So that's 15% of patients who could possibly be missing out on targeted therapy. And coming back to what should be the ideal platform, obviously cost is a deciding factor. If your patient cannot afford a simple, small, 30, 50 gene panel, which looks at the key targets, we can at least help you decide line of treatment, one should go for that. If not, and if your patient can afford, then it makes sense going a little bit on a more comprehensive genomic profiling, just because it's going to tell you the biology of the tumor and can help you, in addition to targets, can actually help you understand what should be the next line of treatment and maybe help guide and make a decision based on that. The area of head and neck cancers is extremely promising. There are a lot of clinical trials, and some of these I've already kind of spoken about. So this is just something to be on the lookout for. So, okay, this just suddenly stopped. But the key takeaway is, molecular profiling, I think, is very important in head and neck cancers. Thank you.